So we are now going to hear from Jan Rivers on affirming distress as identity, uh, talking about New Zealand's transgender health guidelines. Jan is a former public servant whose roles focused on libraries and information systems. As a lesbian, she's concerned about gender ideology and its impacts on young same-sex attracted people. Jan has carried out a review of the PATHA guidelines that have led New Zealand's gender medicine health pathways since 2018. Welcome, Jan.
Oh, thank you, David, for that introduction, and tēnā koutou katoa to people watching. My paper is an assessment of the 2018 guidelines, as David had said, and there'll be lots of reflection, kind of synergies with the talk that you've just heard. So my paper is an assessment of the 2018 document guidelines for gender-affirming healthcare for transgender children, young people and adults in Aotearoa, New Zealand, published initially by the Transgender Health Lab at Waikato University. After the formation of the Professional Association for Transgender Health in 2018, they were adopted as a product of that organisation. So I'll describe them throughout as the PATHA guidelines. My investigation shows what I believe is a regulatory failure in the creation of clinical practice guidelines in New Zealand that has allowed for the creation of guidelines that are not adequate. The impetus behind this work was a news article that said that the PATHA guidelines had never been assessed by the Ministry of Health. My qualifications: I'm not a clinician. I do aim to be accurate and fair, but I'm not disinterested. As David mentioned, I'm a lesbian dismayed by the large numbers of lesbians and would-be lesbians and gay men persuaded that they're in the wrong body. And I've noted that the detransitioners whose gender journeys are in New Zealand's public domain now all understand themselves to be same-sex attracted adults. My working life involved knowledge and information management, ensuring that government organisations have good quality information and are able to retain their institutional knowledge that makes their organisations fit for purpose. Ethical issues loom large in this work, and I think it informs the piece of work that I've done. I hope my assessment spurs others who do have clinical expertise to review whether the adoption of the PATHA guidelines to guide the treatment was the right one. To provide an overview of this talk, and I'll move on to the next slide. I will look at these issues. There's quite a lot of framing and scene setting because it's a complex issue. This slide's a bit confusing. If you regard the last two bullet points as they shouldn't have been, they should be left aligned. So what I do is I outline the four research questions that I responded to. I provide some definitions and explain the players and the interesting and unusual aspects of gender medicine. I look at the extensive reach of the guideline within New Zealand society. I explain what I mean by regulatory failure and show how I believe the adoption of the PATHA guidelines is an example. And finally, I'll provide some surprising quotations from and about the PATHA guidelines. And then finally, after all that framing, I'll describe the research and the findings in detail. Here are some definitions. A clinical practice guideline is a structured, evidence-based document that's been created to meet standards as far as possible, corresponding to one of the clinical guideline creation tools. This kind of guidance is provided by august organisations like the US Academies of Science, the National Institute of Clinical Excellence in the UK, the World Health Organization, who all have guideline creation checklists and methodologies. Another one is created by experts in the evidence-based research field. It's called AGREE, and AGREE is an acronym standing for the Appraisal of Guidelines for Research and Evaluation. The counties Manukau, I'll just do a little bit of setting these guidelines in context. The counties Manukau guideline is the one that the PATHA guidelines replaced. It was published in 2011. The World Professional Association is like the parent organisation of transgender health, It produced standards of care in 2012. They were called SOC 7 or Standards of Care 7. And PATHA say that their guidelines are based on SOC 7. A newer version was produced last year. WPATH standards of care are by no means a panacea, but I'm happy to take any questions about that, but this is not the topic here. PATHA is a local instance of WPATH, and similarly OzPath is a local version, or a local organisation representing WPATH's kind of philosophy. It was created in 2019 after the Waikato guidelines were published. And I'll just have a quick look at the treatment steps. What lies behind these treatment steps is a very unusual basis of informed consent that the guideline describes. First, the definition used in PATHA describes informed consent in this way, as something that reaffirms the self-determination of the transgender person and their knowledge of the world, their knowledge of their needs, identities and self. It counteracts pathologizing. It's a series of conversations about the individual's gender embodiment goals, including a discussion of their risk assessment and likely benefits. This doesn't sound to me like the normal formulation of an informed consent process. And I've seen the Health and Disability Commission describes informed consent quite differently, especially when off-label medicines are used as they are in gender medicine. Secondly, gender medicine has inbuilt pressures that embed continuation. Affirmation, importantly, is an alternative to diagnosis. But where else do clinicians affirm? Affirmation just makes any medical step more likely, whereas open-ended inquiry would not. Social transition leads inexorably to puberty blockers and then into cross-sex hormones. Thirdly, patients with I have some notes here and I just want to make sure that I'm really clear about what I'm saying. Patients with gender issues are distressed, vulnerable and confused. A fundamental way of addressing mental distress is exploration, seeking explanations and understanding. People in helping professions don't generally affirm distress. They identify its causes and seek to ameliorate them, whether they're mental constructs or external conditions. I believe that affirming distress instead of evaluating it is cruel. You feel like that? You feel like shit? Well, if the cap fits. In contrast, affirmation supports a cross-sex identity and supports the view of the patient rather than diagnosing or assessing them. This is novel in medicine. I'll just go on to the next slide. Again, this slide is a little inaccurate. The first 5 lines describe my research approach. My assessment is that the clinical practice guidelines should have been created using a structured approach, using a clinical guideline practice development tool. If not, why are they? If not, they're not clinical practice guidelines. If they weren't, then shouldn't they at least meet the much lower barrier of complying with the evidence-based parent organisation in the case of WPATH standards? This is the standards of care from 2012. And thirdly, if this PATHA guideline makes new recommendations, shouldn't they be supported by evidence? Finally, the PATHA guideline makes some decisions about framing. Are the Maori health models used as intended? Are the claims of Indigenous gender identities supported by the evidence? On to the next slide. I'd just like to provide you with a few quotations that are in the PATHA guideline. The PATHA guideline states, all health services provide equitable and accessible gender-affirming healthcare services that align with international standards, evidence-based literature, and community feedback. The guidelines also explicitly support the development of health services, are intended to support the development of health services providing gender-affirming care around the country and provide guidance to district health boards. But when I wrote to the Waikato University concerned about the quality of the guideline and with a copy of my paper, the response from a Deputy Vice-Chancellor was that the matter of whether external organisations are elected to adopt these guidelines and recommendations and how they apply them is not something that the university has control of. External organisations have the responsibility to oversee the type and extent of advice that they provide to their clients and the resources that they use to provide that advice. So we have a situation here where a tertiary organisation can create a clinical guideline and tout it as evidence-based advice to district health boards and to the Ministry of Health. But when asked whether the guideline is of the required quality to be a clinical guideline, the head of research says that organisations must in fact satisfy themselves. There's a big disconnect here, and it must be seen as an aspect of regulatory failure. But despite the recent failure of the university to endorse its own work, the intended purposes of the reach of the guideline, the guidelines reach has been extensive. The guidelines have been adopted but not assessed by the Ministry of Health, and they're the principal advice on the website of Te Whatuora. They've been used in the creation of health pathways by district health boards. They were explicitly cited in the rolling out of policy that made Victoria University's student health service a barrier-free service for access to gender medication in a paper titled A Little Bubble of Utopia. And they're implicitly used as the framing for the anti-conversion practices legislation as well. Basically, that legislation says that no one is ever wrong about their gender self-assessment. This is affirmation written into our laws. They were also used to create the case for funding for surgery. They were implicit in the approach to the Rainbow Guidelines for fostering and care home sectors. Foster carers and care providers who don't readily affirm children within their care with gender confusion will lose their contracts with New Zealand's Children's Ministry, or Oranga Tamariki. They're also used in the voluntary sector to argue for inclusion and diversity policies, and in schools to argue for the use of pronouns and the provision of gender-neutral toilets. In fact, a search of the URLs where these guidelines are referenced is far more prolific than I was really able to describe. Go on to the next slide. This slide discusses how all this came about. When I talk about regulatory failure, this has to do with our governance structures and them being insufficient to protect people from bad outcomes. There's plenty of evidence in New Zealand of this, chains of events that lead to highly negative outcomes, leaky buildings, drug testing, dodgy investment schemes, lax rules in dangerous industries such as farming, forestry and ports and railways, and issues in healthcare like the surgical mesh. These issues have cost billions of dollars, created misery in thousands of lives, and have caused lives to be lost. I think the regime for gender medicine is another example of regulatory failure. The diagram I've got here describes part of the problem. There appears to be no standard in our health system for creating clinical practice guidelines. The organisation that did provide the overview was allowed to go into receivership. Self-selected groups of physicians can create documents that purport to be guidelines without aligning them to international good practice on the creation of guidelines. The regulation would ensure a better approach doesn't seem to exist. And at this, yes, on to the next slide. So that's regulatory failure in a nutshell from my perspective. And then this next slide goes on to the research itself. So and there are 4 slides which describe my research. So basically, the research questions that I asked were, do the guidelines meet the standards of a clinical health guideline practice method. If they reflect what was in the WPATH document, and if not, what's the evidence for the changes? And then finally, these other questions about complying with Maori health guidelines, and also the nature of Indigenous gender identities. I took 3 of the tools for this first part, the comparison with whether the PATHA guideline is a clinical practice guideline. So I documented the features of 3 clinical health guideline methodologies. They were the AGREE methodology that I mentioned, and those from the American National Academy of Science and the World Health Organization. There were 8 of them that were obvious and in common. Then I examined the PATHA guidelines for evidence of these required elements. I found 8, and they're summarized on the slide. There are the people issues at the top. Are we involving the right clinical people? Can we define the right population to be treated, or the interventions required? And do patients have a voice, and other clinicians have a voice in all of this? At the center of each clinical guideline practice methodology is the way it formulates clinical recommendations. How do you identify the relevant research? How do you differentiate between poor and good quality research to decide which to include in consideration? How do you create a clinical guideline recommendation from the literature you have? And what weighting does each recommendation have? The next group of issues relates to proper practice and assurance. Is there evidence of an independent review? Is there a process for dealing with conflicts of interest? Is there a plan for new releases? So in the next slide, I describe what my findings were. None of the requirements of these clinical practice guidelines are fully met. One of the important features of clinical practice guidelines is that method of creating them is explicit. In other words, contained within the guideline itself is information about how it was created. None of this is in the PATHA guidelines. As far as the skill sets, none of the authors appear to be surgeons, psychiatrists, or endocrinologists. The one group, however, who are fully included in developing the treatment guidelines are representatives of the transgender community who were front and center. The guidelines say transgender people have been involved in the steering of the project, including development of services and these guidelines. The importance of the trans community leadership in the development of trans healthcare services is paramount. This is fine, but it's quite unusual, surely, for the treatment group to determine for the treatment group to determine their own healthcare services in quite this way, especially when most of the patients are children or young people. Imagine heart surgery or diabetes treatment run like this. As far as the population of patients is concerned, the PATHA guideline fails completely to identify that the population are a rapidly growing group with a changing cohort, including many post-pubertal young women with multiple mental health issues and other issues who are claiming that they're men. This information was apparent even in the New Zealand statistics, and it was being observed in published papers as early as 2015, including one by Dr. Rita Kaltiala, the leader of the Finnish gender program. Assessing this enormous growth and the rapidly changing demographic as people being free to be who they truly are because of societal change is not simply incurious. I believe it is incoherent given the emerging changes. The biggest gap, though, is the lack of evidence that a literature review was ever carried out. There's no information about the search criteria, there's no criteria for assessment of articles found, there's no methodology described for how recommendations were derived from the evidence and linked back to it. These are the things that should be at the very heart of the PATHA guidelines. Instead, there were only 52 citations, of which barely half were peer-reviewed research. The guideline also lacks any information about these managing of conflicts of interest, an independent review or future versions. Does this sound to you like the all health services provide equitable and accessible gender-affirming healthcare services that align with international standards, evidence-based literature, and community feedback that the PATHA guidelines said was necessary? The second part of my research was an examination of how the PATHA guidelines compare with the WPATH guidelines. You'd expect that if that were the case, that we would find the evidence in the WPATH guidelines. But the PATHA guideline makes more extreme recommendations than the WPATH standards of care across every dimension that I investigated. There is mostly little evidence and no explanation for these changes. I'll give some examples. I may not have time to go through all of them, but they all apply. In WPATH SOC 7, there's a recognition that neither treating nor not treating are neutral actions. In contrast, the WPATH guidelines says only that withholding gender-affirming treatment is not considered a neutral option. No evidence is supplied for this change. In the WPATH guidelines, it's recognised that the large majority of prepubescent children who take on a cross-sex identity will desist. In the PATHA guideline, it says merely that some previously gender-expansive children may shift across along the gender spectrum, to find their gender identity more aligned with their sex assigned at birth. No evidence is supplied for this change of emphasis. The WPATH standards of care recognise that social transition to the opposite sex is controversial, and if it occurs, that children and young people must explicitly be told that there's a way back. In the PATHA guidelines, no such advice is given. No evidence is applied to support this change. The WPATH standards of care argue for a medical diagnosis to exclude other causes of cross-sex identification, such as psychosis or trauma. The PATHA guidelines do not even use the word diagnosis in relation to the decision to provide social transitional gender medicine. In the PATHA guidelines, the clinician's role is to follow the patient's perception of their own gender identity, saying clinicians must recognise that each individual is the expert of their own gender identity and that their unique journey needs to be acknowledged. No evidence is supplied to support this change. In the WPATH standards of care, affirmation is used, but in the context of clinical assessment and diagnosis. So these go along with, you do a clinical assessment, a diagnosis, and then you affirm. In the PATH guidelines, affirmation is the approach, regardless of mental health issues, trauma, autism syndrome conditions, and even the ability to verbalize across gender identification. No evidence is supplied for this change. In the PATHA guideline, in the WPATH standards of care, it's accepted that comorbid mental health conditions may impact any treatment unless they're well controlled. In PATHA, poor mental health is no bar to gender medicine, which may continue in the presence of any mental health condition, and it can be assessed by a prescriber. This is a quote: "It can be assessed by a prescribing provider or a mental health professional who is experienced or competent at working with trans people." There are differences as well in the way that mental health conditions relate to gender identity, and also in the way that blockers are described. There are 4 prior criteria before you provide a child with puberty blockers. In the PATHA guideline, there are none. I think I'll move on now, but basically the difference between the 2 guidelines could not be greater. And in none of these cases is evidence provided. Professor Te Awekutukortuku will have much more to say on this topic generally, but my comments about the way that the PATHA guideline speaks about Maori health frameworks and Indigenous genders is what I specifically want to speak to. And I believe that they're being used opportunistically to achieve a specific objective. My comments relate only to the PATHA guidelines and my concerns that the references to the Maori health frameworks are being used in a way that is not correct. I have the greatest respect for the work that's been done to systematise Maori concepts in healthcare by Sir Mason Dury and others. Using these models to develop a new paradigm of evidence-based Maori mental health care has been done carefully and done well, but I don't think it delivered in this specific instance. To provide a couple of examples, is it possible that the autonomy of iwi and hapu to co-design service delivery in settings like the development of public health screening programs is the same as the principle of trans people's autonomy for their own bodies represented by healthcare provision based on informed consent? In my opinion, these things are quite different. It's far from clear that a public health communications tool intended for working with iwi was ever intended to make the case that healthcare should be fully self-determined. In a different example, from Te Wharu Tapu Wha, it's a useful holistic health model, of course, allowing the impact of whānau and family to be put alongside mental and physical health. It's a tool that achieves much that Western medicine paradigms may miss. But in the novel setting of its use for a clinical guideline, it has the effect of separating related material. So, for example, mental health is addressed in the chapters on family, on spiritual health and mental health, making it very difficult to understand a complete picture. The section on social transition is separated from the information that some children may desist from cross-gender identification, again, making it hard to understand the impacts. Finally, and most importantly, the PATHA guidelines say that it's increasingly apparent that in Aotearoa pre-colonial Maori society, people of diverse genders and sexualities were both accepted and valued within whānau. When I searched the 3 references cited, I found nothing that substantiated the claim that was made about diverse genders. There may be such information, but it certainly wasn't in the documents that were cited in this in the guidelines. So, how does PATHA's claim about evidence-based medicine sound after this? I've thought a little bit about the next steps. The PATHA guideline fails to use a formal guideline approach, clinical approach, to support major changes from the standards of care that were its reference point. It's my belief that giving primacy to views and wishes of transgender adults to lead the creation of treatment which is mostly for children demonstrates why the recommendations are so different to the WPATH guidelines. Things are changing fast, though. As well as the launch of the Genspect gender care framework, the American Association of Pediatricians is being prosecuted for the creation of its own 2018 guidelines. It has the same kind of affirmative, one-size-fits-all practice as PATHA's. Like the PATHA guidelines, a diagnosis-free affirmation approach to assessment has left many young American people adrift in bodies that are not what they hoped for, and which, now changed forever, cause them pain and distress. Some of these young people want to see justice. I do believe that if the Ministry of Health had assessed the guidelines before they presented them on their own website, they would not have been adopted. I believe that the Ministry of Health should have, and indeed would have, sent the authors back to the drawing board. We really need to address in New Zealand this issue of being able to create clinical guidelines, especially for a large, burgeoning, changing population, and where the impacts of medication and surgery are so extreme. It's not appropriate that they be managed through a guideline which has never been given a proper appraisal by parties other than those whose interests are in the very medicine that they're developing the guideline for. Thank you very much, and I'm happy to take questions.
Jan, thank you very much for your analysis and presentation. I want to start by saying that, as I've listened to you, you've talked about regulatory failure in terms of poor process in developing the guidelines. But are you implying that, particularly where public bodies like the Ministry of Health are involved, this may also be a failure in terms of democratic and ethical implications? Could you expand on just the implications of poor process, particularly in relation to public bodies?
I guess, how can I answer that question? I think, and Joe and Alistair alluded to this very strongly, which is that the extent to which organisations have been captured by gender medicine, by gender ideology rather, and I think that is part of the problem. So, for example, we have the Public Service Commission advocating the use of pronouns, and they do this on the basis of care and compassion. But you have to ask whether, if someone begins to use pronouns, that have they not adopted a particular ideological position? And if they're putting pronouns in their biography, in their bio, in their emails, and asking for pronouns at public meetings, how can they then assess the problems with gender medicine, for example? Would that not immediately be regarded as problematic? It seems to me that impedes the very adoption of gender theory ideas into the public sector, impacts on the ability of public servants to provide free and frank advice, and particularly when any kind of challenge to these ideas is being regarded as hateful and bigoted. I've got some other areas as well. I mean, one of the things that often happens is that legislation is being misrepresented, in my opinion. For example, the Human Rights Commission now describes sexual orientation as same gender attraction rather than same sex attraction. Now, to the average reader, this would be very subtle and probably would not be noticed, but the difference could not be more enormous. If lesbians are same gender attracted, then they are attracted to any person who regards themselves as a woman who is attracted to women. And that's a big issue. It nullifies the lives of lesbians if the people that they're attracted to are men who just happen to think that they are women. There are lots of other issues around. One of the other areas that, this is a related issue, the Births, Deaths and Marriages Act provisions that allow for passport, for birth certificate change. They simply refused to entertain the idea that there would be any impacts of this on women. And usually the practice of the public sector is to take a rounded view, to look at all of the evidence, to consider different perspectives, to understand the viewpoints, and to try and find solutions and policies that reflect the broad majority of people. But if you simply refuse to look at evidence that comes from one side, then you damage, I think, the body politic. The same thing happened, I think, in the select committee processes for that bill and also for the Conversion Practices Bill. Thank you. Yeah, that's what I've got to say.
Thanks, Jan. I'm just looking at some of the other questions that have come through in the chat. And there's one that's popped up that you may or may not know the answer to, but do you happen to know whether it's true that slow-release testosterone patches are virtually free in New Zealand and have been for some time?
I'm not. I wouldn't have been aware of that. I am aware, however, that some young people obtain their hormones not through the legal system. And I'm certainly aware that a large number of young women who are taking testosterone. But no, that's a surprise to me.
And then there is another one that's come up. Do you know where the Otago Medical School or University of Auckland Medical School sit in respect to the guidelines, given that University of Waikato doesn't have a medical school, at least not yet?
Where does the Auckland Medical School sit? That's. I mean, I haven't investigated the stances of either of the medical schools, but I have looked at information from the Royal New Zealand College of General Practitioners, from the Ministry of Health and other organisations. I mean, I'm aware that the Goodfellow unit has done, which is part of the University of Auckland, has done extensive training on which reflects the provisions of the PATHA guideline, and I'm not aware that it's done different kinds of training that might be or provided different kinds of information that might take a more critical stance.
Thanks. Another question: have any current MPs been willing to engage with you, and who might be willing to put up, say, a private members bill around banning gender ideology in schools and affirmation treatment?
That's an interesting question. During the previous 3 years, I wrote many letters to MPs and also including the Minister and Associate Minister of Health and their shadows. And on no occasion did I feel that the kinds of comments that I made really heard. And certainly there were no offers of meetings. However, we're in a post-electoral period, and I guess everything's up for grabs. I do believe that the way that the Labour Party has approached its opinion polling in the aftermath of the election may be an interesting indication that they understand that their approach to these issues has not been entirely favourable. So I think there is some reflection. I hope there is some reflection going on there, and I'm not familiar enough with the people who might be in the new Parliament to know whether there is a possibility of a private members' bill. I certainly hope that there might be.
Thanks.
Yeah, and I think sorry. Oh God. One thing I was going to say is that in various countries there are moves afoot to ask for a review of gender medicine, and there is a petition available at the moment on the New Zealand government website asking for a review of gender medicine, and I think that's where there is certainly some possible opportunities.
There's a lot of appreciation coming through in the chat for the analysis that you've done, and a question about where can we read the report on your research?
Can I supply a link to you that can be displayed?
We'll find a way to do that.
Great. Yes, it is published, and I've got a previous version on the Academia website, but it's a little bit dated, and I've got the version that I'm speaking from now is published elsewhere.
Thank you. Jan, you touched in your presentation on the legal cases being brought against the American Academy of Pediatricians.
Mhm.
As you've thought about that, how do you see that case being relevant here in New Zealand, and what can we learn from it?
Um, well, of course, we're in a different situation in New Zealand because of the ACC and the no fault legislation, and that's both. That's obviously a very good thing in many respects, but it does mean that the pathway to potential legal actions are somewhat more limited here. But I must admit that when I saw that the action that is being proposed against the American Association of Pediatricians, the opportunities, or the parallels between that legal case and what the PATHA guideline has done in New Zealand I felt were quite strong. What happened in the States was that 2018, the American Academy of Pediatricians released its affirmative guidelines. They were very quickly critiqued very, very heavily by a man called Dr. James Cantor, and his um, assessment of them has never been responded to by the American Association of Pediatricians, although there have been a number of doctors who have sought to have reviews of the guideline made at various of the association's conferences, and which led not many months ago to the American Association of Pediatricians deciding that it would change its policy. As far as I think one of the things which I have discovered as I've investigated this area is that where responsibility lies in the New Zealand medical system is a very vexed question. And what lies with Pharmac, with MedSafe, with the Ministry, with Te Whatu Ora, with the Royal New Zealand College of GPs, with the Medical Council, and with the Health and Disability Commissioner is a bit of a tangled web, to be honest with you. And I think that we need, when we have a detransitioner or a parent who is keen and eager to take a case because of the ramifications of what has happened to themselves or to their child, then we really need to unpick what the opportunities are. But that's it's a little bit of a tangled web, I think.
And one last question I'll put to you before we close. You touched on public servants, for example, using pronouns, and I
Hmm.
certainly see this a lot on LinkedIn, and someone in the chat has commented on this. Do you happen to know whether the Public Service Association has ever taken a view on this?
Um, I looked for it in the preparation of this because I wanted to mention it. I am certain that I have seen an article in the Public Service Journal praising the stance that was taken by the Public Service Commission, but I don't. I couldn't find it when I came to present this paper, and it's occurred to me many times that I should write to the Public Service Association to raise, and others should as well, to raise our concerns with them.
And the Public Service Commission itself uses pronouns, I see.
Well, one of the things that I have noticed is that the origin of a lot of this is the new Public Sector Act. And the Public Sector Act very wisely and very well gives chief executives the responsibility of addressing diversity and inclusion in each agency for which they are the chief executive. But unfortunately, because those skills weren't available within the public sector, the capacity had to be built, and the capacity has been built by bringing in some of the supposedly LGBT organisations within New Zealand who have largely ceded their roles to being the T of the LGBTQIA, And what that has meant has been that some of the training, and there's evidence of this in some whistleblower accounts, which is that the training is highly ideological. It reflects the same misinterpretation of the legislation around same gender attraction as the Human Rights Commission does, and it presents a highly skewed perspective on the LGB, on the rainbow community, in my view, and often an inaccurate one, and often one which reflects the law as those organisations would like it to be, rather than the way that the law actually is. There's an
Yeah,
expression
thank
for
you,
this in
Jan.
the UK. Yep. Thanks very much.
Well, we'll call to a halt there. Thank you so much for the work you're doing and for presenting it to us today.
Thank you. Thank you.